For example, we have a patient that comes in with a missing number 11, but they have an abfraction on number 18. On the surface, those might be unrelated, but what kind of value could we glean from having that abfraction on number 18 be part of the treatment planning workup?
So just having other problems made aware to the patient shows them that it's a more complex system than just that one problem they think they have. And you're accounting for all those issues together so that they're seeing that, well, we're painting the picture for them that, you got more going on here. And if you want it done right, we do it all together in an order that makes sense.
Great. Yeah. Thank you, Luke. So building value in the eyes of patients for the future. So it may not be such that the patient looks at this and says, well, because I have an abfraction, I now know I have a wear problem. And that wear problem, or let's not call it wear, but parafunction, might be relevant because a canine on tooth 11, missing that tooth and having number 18 tells us that there's a biomechanical problem in the system. We know if we put an implant in number 11 in a patient that has a biomechanical problem, we're likely to have failure. So if we just put the implant in there and we ignore the signs of the rest of the mouth, the likelihood of that implant failing is much higher. Well, if we explain that to the patient, if and when it happens, we're not buying them a new screw, prosthetic screw. We're not buying them a new crown because they fractured off the crown, or worst case scenario, bone loss around the implant and then replacement of the implant is really what we're trying to avoid. In addition, that patient might have further issues down the road, and each time we have a touch point which we can educate the patient to understand they have a bigger problem than any other dentist has shared with them, we plant a seed and we water it over time. And given 10 years, 15 years of reminding our patient that they have a parafunctional or biomechanical problem, they're much more likely to do something 15 years from now. So it's a lot about patient education. Does it mean that we have to do something comprehensive? No, but the patient becomes aware and they can own their problem at that point. So we can imagine if we had an abfraction on number 18 down here, and I'm using this to simplify it, but I think we get the point. On the problem list, we have abfraction number 18, missing tooth number 11. Another problem we would put is loss of canine guidance. That's a problem, and what that means is we're losing protection of the back teeth. One could argue that those two things are actually related, and they likely are if that was a scenario that we saw. But it's that loss of the canine guidance that provides a bigger picture problem that puts the other teeth at risk. So I've seen over the years when patients, let's say we put an implant at number 11 and we don't necessarily create proper canine disclusion or disclusion of the posterior teeth and they break a back tooth. That often happens after you put the crown in number 11 because it changes the envelope of function, and sometimes that can increase the risk of a tooth breaking. Well, what if a patient comes and says, look, I haven't broken any teeth in 10 years. You put this implant and crown in, all of a sudden I broke 3 teeth. That's a slightly exaggerated example, but something that does happen. We can always come back to, well, just to remind you, like we talked about on our treatment planning form, you have a parafunctional problem. Oh, yeah, I remember that. Part of the goal of this is to avoid those situations where patients are blaming us for their problems. So identifying everything that they have is a safety blanket moving forward. Safety blanket for us when we're talking to them in the future. Safety blanket if they were to report us to the board. I can't imagine if the dental board got something like this in their, record acquisition, they're going to look at us as a completely different kind of dentist. They're not going to be like, these people are going too fast and that's why they chose something. So it's just being thorough, but there are times when those small things that are unrelated to the chief complaint do play a role, maybe in the near term, maybe in the long term. The other part of this that Ryan and I were talking about when you create your problem list and you create your set of solutions, you can build the value of these different cases or different strategies or different options based upon the percentage of problems that you solve. So if you have a list over here and you create a set of options and then you go back and you say, well, I created a set of solutions that only address 50% of the problems. The patient needs to be aware of that. Patients have no idea. How many patients have we had? You make them a partial and something breaks or the partial breaks and we're like, yeah, but you chose a partial. They don't have any idea. In our mind, they chose the cheapest option, but they're not going to remember what you shared with them during that treatment plan consultation. Recent studies showed that patients chair side remember less than 40%. I always thought it was 20%, but the number is paltry, meaning the amount of information the patients remember when you describe it to them is very minimal. So if we're going to rely on our treatment success being remembered by the patient, it's just not going to happen. So this sheet allows us to say, well, underneath the cons of treatment option 1, which was a partial, one of the cons was many of your problems are not addressed. So we've all used that tagline to help articulate to patients that, yeah, you're choosing something that's just kind of a wedge in the door. You know, it's a wooden leg is one thing I like to tell patients. Does it help you walk? Yes. Is it going to help you win a marathon? No. So connecting these two together is very helpful. Most importantly, being able to tie in how many of the problems you addressed with each of these solutions. Does that make sense? Anybody want to add any insight there?
I think one thing that came up today, I was doing a case presentation in Naples, and I was meeting with the patients about what I had sent them, these 2 sheets. And we had walked through what we were going to pick, but at the end, he was telling me about his periodontist, and he was like, honestly, I went and showed my periodontist this, like the sheets, and I asked him what his opinion was. And he even said his periodontist was like pretty impressed. He's like, you found a dentist that went through all this time addressing stuff and came up with plans. Like, if they can all do it in one house, like, you found a great dentist. Like, he said that it's almost like he went to the periodontist to like double check.
Right.
Like, is this guy real? And the periodontist is like, no, he's spot on.
Awesome.
So that was pretty cool.
Yeah. I mean, he probably didn't know what to do. I mean, I've never seen a treatment plan that is anything other than a printout from Dentrix or EagleSoft. Which, that's not value building, that's just what the plan is. I mean, there's value to that particular way of doing it, and that's a tool we use, but that's not necessarily something to bring us and the patient onto the same page and then have this to refer back to, so that when a patient says, well, you never told me. I mean, honestly, page 2 was created because I got tired of patients saying that. Now I just say, well, let's, pull up your records, and I show it to them, and they're like, oh, okay, yeah, I guess I forgot. I mean, I feel like there's more wasted energy in a day from patients who are emotionally upset with something that actually involved us putting our best foot forward, but we have nothing to prove. This helps us to prove that. Anyone else want to chime in? All right. So let's go to Daryl. All right. So this is Christian's case. Christian and I treatment planned this last week. Basically, Christian, you want to kind of present it like you presented it to me last week. I think the conversation we had, I wish we had recorded, because I thought it was really cool how we went from your initial question to what I think is a really good resolution.
Yeah, I'll do my best. I don't remember exactly how we went about it, but this is a patient that I brought to Dr. Roy. I had done the workup for this patient, and he just kind of like strung a couple of the heartstrings of, I'm really dedicated to wanting to help this guy out. I know he's financially strapped, but I'll think of something, or we'll make an ideal case, and maybe we give him a heavy discount for the experience, whatever it may be. But I wanted to do something for this guy. He, after talking with Tiffany and kind of like what he can afford, it seems like 14,000 is like his limit of what he can find, which is a lot to play with. But also, I mean, just looking at this right here, you can tell, well, 14,000 actually might not go that far other than partial dentures. That being said, I think we found a really good plan that we can really knock this guy's socks off with such a great outcome with around 14,000. That's what we had talked about. How do we use 14,000? If that is this hard number, how do we give him every penny's worth of his money for a great plan?
Yeah. So if we were to come up with a problem list, let's all chime in here. Christian, you want to start with, was it 8 and 9 or 9 and 10? There were a couple of teeth that need to come out.
Yeah, so right now 9 and 10 are already out. He came in with, he had abscesses on them. He actually cracked like 10 and a half. So if you can imagine, 9 and 10 are already out, and 8 is also like needing to come out too. Periapical abscess, heavy recurrent caries. I mean, it looks fine on the outside, but it's not. So 8, 9, 10 are all, well, 9 and 10 are out, but 8's also needing to go here. Everything else except for, I think it's 28 also has to go. So everything else is fine except for 8 and 28.
Yeah, what's interesting here is this guy doesn't have many opposing teeth.
No.
That are still structurally sound. So the upper right, they don't have any opposing teeth. 27 and 26 don't really have any opposing teeth. The upper left, no opposing teeth. The tendency is to want to give this guy a partial, and that partial is going to last 3 years. And it's not the partial that's going to fail, it's the teeth underneath them. And this is how we're taught. We're taught, this guy doesn't have any money, so he gets a partial. And Christian's first question was, do I have enough vertical space to do the partial? So that was where we started the conversation. And I think what that did, it forced us to think outside the box a little bit. So before we start talking about solutions, what are some problems here? So obviously missing teeth, periapical abscesses, he needs a couple teeth out in the front. Biomechanical problems. Anybody else want to chime in? There's a
Collapse vertical.
Definitely. Collapse verticals and partials, it requires some thought. And that was really, to Dr. Labani's credit, he knew that. He just didn't know how to solve it. Collapse vertical is huge here. And it may or may not be the reason why he's got biomechanical problems. We know that when people have deep bites, their masseters in many patients absolutely hate that. And their masseters are just constantly pissed off and destroying their teeth. We see it all the time with entrapped cases. So Elena, entrapment is this term here. So upper incisors, lower incisors. When the lower incisors want to be where the upper teeth are, we call that entrapment. We'll talk more about it as time goes on. But it's a very common clinical problem that is highly overlooked. And as soon as you solve it, the patient's TMD goes away, their breathing improves, and their need for parafunctional habits decreases. So if we're going to try to fix this guy, we need to fix what got him here in the first place. And I think a lot of it is potentially entrapment. What are some other issues here?
He's got some old leaky fillings too. Some fillings that are starting to break down on the back. He's missing a bunch of teeth, obviously.
Wait, the vertical's gone. This is it. This has really happened. This is it. He's lost his vertical.
Yeah. Do we know that for sure?
Yes.
How?
No teeth are unmarked or in normal contact where they once were. And he's lost his posterior support bilaterally. Like maybe 22 has saved the day, but I'm not positive. I'd have to look at the model.
So determining whether a patient's lost vertical or not is very challenging because of the fact that compensatory eruption, when we lose teeth, our teeth drop down or rise up, can make it look like they lost vertical. But in reality, if we look at the CEJ of 22 and the CEJ of 11, he might not have lost that much. I think he has some attrition on 11. 11 has super erupted to some degree, but he actually isn't so much collapsed. And if we look, I don't want to do that now, but if we look at his photos, we could get a sense of where his nose and chin are in relation to each other to determine whether he's lost vertical. So I don't think you're wrong, but the easy solution in cases like this is to say the patient's lost vertical. And the reason why that's important is if that was his true diagnosis, the solution would be to open him back up 15 millimeters. That might look really funny in his face. So getting the diagnosis right so that you can get the right solution so that it looks aesthetically pleasing and functions well is important. So if I had to say, just based on the relationship between the canines, I would say he's lost 20% vertical. The rest of it is all just super eruption due to wear and loss of teeth. Super important concept. Anybody have any questions about that? Does that make sense? Not to shoot you down, Zach. What else do we see here? So we talked about this last week.
The cupping,
Yep. What
which means there's
what is cupping?
probably
cause?
got to be some gastric component too for that wear pattern to exist.
Yep. So cupping can only happen when? You kind of said it, but it's good to have this line in our repertoire.
Erosion, like from acid, you mean?
Yep.
Yep.
So cupping only happens when you have both attrition and erosion. So do we think this guy might be an airway patient? Deep bite, erosion. He's a man in his 50s.
I've always just assumed if Dr. Roy asks if this patient is an airway patient, it's a unequivocal yes.
50% of the time, it's right every time.
Yeah, every patient's an airway patient.
That's right.
We should get their BMIs. We should start getting everybody's BMI in a professional, non-intrusive way.
I mean, Chantel could get that. She could.
Just be part of the conversation,
If
yeah.
anybody could ask how much do you weigh and not piss the person off, it's Chantel.
100%.
All right, any other problems for us to look at here? And I think we've gotten the big ones. Obviously, bone loss. If we looked at the CAT scan, the odds of us being able to place implants here without a ridge augmentation is probably slim. And obviously, when Dr. Labonte treatment planned this case, he went through all of that. But I wanted to walk through how to solve this guy's case with $14,000, which, Dr. Labonte said, it's a lot of money, but it's not. All right, so we have our problems. We send the patient to Ray to get a sleep study done. Turns out he has moderate sleep apnea. His AHI is 30. Ray says, well, we're not going to make an appliance on these teeth. Dr. Labonte, go ahead and finish his treatment plan, and when you're done, send him back to me, and I'll make him an oral appliance or send him off for a sleep study to get a sleep apnea, a CPAP machine. So important to build that value before the case, because when patients are done with us, they're often done with us. The last thing they want to do is go see Ray. So we have to build that value early on. But we know we need to build this guy back up. So we have option 1 is removable. Option 2 would be crown and bridge. Option 3 would be crown and bridge with some bone grafting and some implants. And then option 4 is an all-on-4 upper-lower arch. Not a recommendation, but an option. So the guy says, I have 14,000 without getting into the weeds of what we talked about last time, because we spent a couple hours on the phone. We realized that we can only really solve this using partials, but we have a lot of money to create a very nice outcome for this guy with partials, with surveyed crowns and opening up his vertical. So what would be the classification, Kennedy classification for this case? Dr. Labonte, you said 8, 9, and 10 are all coming out?
8, 9, and 10 are all not going to be part of the plan.
He currently has 8, right? But 9 and 10 are gone? You've removed those?
Yes.
Okay.
Exactly.
All right. So
Class 2 mod 3 for 100.
daily double. How much would you like to wager?
It was her answer. It wasn't me.
Oh,
Well, it depends if you're replacing the second molar.
that's a good point. No, we're not replacing it.
Okay. Then class 3 mod 2.
All right. So the reason why I think it's important to know the classification, different classifications have different risk profiles and problems associated with them. Kennedy class 3s cross the midline, and when you cross the midline, you're likely to have a sagittal rotation, this way. So counterclockwise. As the patient functions on the front, there's going to be a reciprocating force out back. Now, it's true we're going to have clasp to help hold us in, but over time that can cause a problem. Where's the other common scenario in removable prosthodontics where this counterclockwise rotation becomes relevant?
Combination syndrome, is that what you're talking about?
Yeah, what is combination syndrome?
It's like, what, maxillary hypertrophy and anterior, like, mandibular eruption, something like that?
What is the clinical scenario at which you're likely to see it?
Maxillary mandibular teeth.
What mandibular teeth?
Anterior.
Anterior teeth. Yeah, so when you have that clinical scenario, you get rotation of the denture over time, you get resorption of the premaxilla or the anterior maxilla, and then the denture kind of creates this rotation out back and you get hypertrophy of the tissue. There's a commercial, I don't know if you guys have seen it, I think it's Ira Rosenberg on TV. He has the worst case of combination syndrome. His denture is like this. You know, it's very unesthetic. Well, that's in a complete denture. So we can draw that same conclusion with Kennedy class 3s. We have that same kind of biomechanical problem, which is important because we want more sturdy teeth out back. That might lend us to want to create more strength in these posterior teeth. And we also want to educate the patient that that entire flange in the front is going to be likely to break. It's a very fragile part of the acrylic. So we want to build the value in the eyes of the patient of what is at risk here. So knowing the different Kennedy classifications is important. What is one problem that occurs when you have a patient like this who needs a metal framework but has teeth that need to come out?
You're fucked.
I think you
You can't do the framework until you get the teeth out.
Right. So doing a framework try-in.
I'm on live, sorry.
Are you talking to Sophia? Hi, Soph.
Hi.
Elena, Sophia is Dr. Regan's wife and fourth-year dental student, also a soon-to-be member of the SRD team, and also his treatment planning couch partner.
Hi.
Yeah, so putting a framework on so that, doing a framework try-in is somewhat impossible with certain cases. Can you design the framework so that it avoids the teeth? Yes. But would you design the framework for the final solution? that same way? And the answer is often no. So Dr. Labani, what was our solution here? I want to see what you took away from that.
Overall, like what we're going to be doing for him?
How do we solve that particular problem? If we want to give this guy a metal framework partial, but we know, so ideally we want to have a metal mesh on the ridge. The problem is he's got a tooth there.
Yeah.
And not to mention he's going to have healing that goes on. So what was the idea?
We had talked about doing a valplast partial denture to give him something in the short term while we wait for that ridge to heal. We can do other things, which we'll talk about in a second, but giving him a valplast partial, something that we can easily realign, but gives him some aesthetics in the meantime.
Yep. Valplast is not very relineable. With that said, there are other materials. We could do an all acrylic partial. I think the important
like
point
wrought
is
wire clasp or something.
Yeah, wrought wire clasp with an all acrylic. And I have no doubt there's 3D printed technology coming down the road that will help us with it. We're actually going to look at one of those solutions in a bit. But using an interim partial denture is not something the average dentist, including myself, for many years was never comfortable doing because it costs more. So what we do is we often will just charge the patient the lab bill. It's not really that difficult to do. We're not really planning on doing a bunch of adjusting. We tell the patient this is temporary, and we get them to something that they can live with in the short term so that we can take care of some other issues like replacing these amalgams, crowning teeth, creating survey crowns, and letting the ridge heal. So valplast, Duraflex, any of those, all acrylic partial with wrought wire clasps, all of those are great.
What's the perio on those posterior teeth? Are you gonna get a partial on them, and they're gonna
They
fall off?
they were stable.
Yeah.
All of his perio was really right in the front, if I remember correctly.
Yeah, the backs are actually fairly solid. How and why, I don't know, but.
So here's another question. We're going to create a valplast denture. How do we know where to put, or how do we know what to tell the lab where to put his teeth? Are we going to have them put him in the same spot his current teeth are?
No.
What is the solution that we always go to?
Just do a wax rim.
We went with, well, yeah, yes, but based off of his rest photo.
His left
rest.
Yeah.
Yeah.
So we don't need a wax rim if he has a current tooth there.
Does he have teeth there?
He has number 8, I think, still in there. So if he didn't have number 8, then definitely a wax rim. And Hicks actually had a case, which we were going to go over, but it looks like we're going to have plenty to talk about with this case. So we have this rest photo here. We have his wax rim right there. These are gone, but we can tell the lab, please match occlusal plane to the incisal edge of number 8. What other information might we want to convey to the lab for this interim partial?
I guess is number 8 in the right position though? Like why? Like if you put it back there.
I
agree.
Like,
It looks short and stumpy.
Well, not even that. I guess in his occlusion. I mean, are you doing something on the bottom too, or?
This is my son's first day of watching Jeopardy because of the daylight savings change. He's been up, so kind of a proud moment.
Oh.
Sorry, Ryan. What were you saying?
Just what are you gonna do something on the bottom too?
Yep.
Like my fear is like if you put the central there and then he just bites down, he's gonna have a really deep bite again, right?
Correct. Yeah. Opening this guy is going to be a very critical part of what we do, and also Yeah, let's come back to that in just a moment because it's a very good point. I often want to tell the lab where to build the case based upon the patient's occlusal plane. So we could bring the guy back and get a face bow. But what are some other tools that we can use to tell the patient where to place the teeth in relation to the guy's face? So a face bow would be one tool.
Swallow bite.
Swallow bite gives
The-
you a jaw relation, but not the upper plane. So when we're doing maxillary
notch.
records, go ahead, Regan.
So you can also use the frenum, the interior maxillary frenum, and the hamular notch and the line drawn between the two.
It's
But they require a special articulator, right?
Yeah, so he's talking about the HIP axis, which is the hamular notch, which is, has to be captured on the models. So right there, right there, and right there. It's not the frenum, it's the incisive papilla. This is straight out of the world of neuromuscular dentistry. The LVI world does not use face bows because face bows they rely on soft tissue, whereas this access relies on hard tissue, and this is way more accurate. We still use face bows from time to time, but I just wanted to introduce the concept that the neuromuscular world uses, which is the HIP access. What else do we have? So, Dr. Stalker, you were saying a wax rim. What do we have instead of a wax rim?
What do you have?
Let's say this was going to be an immediate denture, and
Is that the canine?
you forgot to take a face bow, and the lab has the case, and the patient's going to Bermuda for a wedding in 2 weeks. But you have everything here. You have a photo. You have this photo right here. Existing teeth are tools that we can use to relay to the lab where we want the occlusal plane to be. Now, many dentists send models to the labs and they make dentures. That's what they do, but that's not necessarily the right play. So if you're a lab technician and you have super eruption of teeth, how do you know where to place the occlusal plane for the complete denture? Again, this is not the case here. I just wanted to relay the message that there's different ways to establish your occlusal plane of the upper arch. One is a face bow, 2 is the HIP axis, and then 3 is existing landmarks in the patient's mouth, primarily teeth.
So does that mean that the interim partial denture, this transitional denture, is just going to look the same as he is now, with just more teeth?
Correct.
Until we move to a position where we can truly open him and change everything.
Correct.
I assume.
Yep. Great segue to the next part. But always remember, you can use the existing teeth as a communication tool for the occlusal plane of the upper arch. What I would say, if this was a complete denture, I would look at the incisal edge of 8 and 9. That's always your starting point. And then I would say, what do I like for an occlusal plane? I would say something to the effect of 1 millimeter above the distal buccal cusp is point A. Point B is the incisal edge of number 8. And point C is 2 millimeters cervical to the distal buccal cusp of number 15. I mean, that's just an example. You just describe to them 3 points and then say, create the occlusal plane at that point. You're looking at the photo or you're looking at the patient, but you're not necessarily having to do a face bow. Obviously, if they have no teeth, then something like a face bow helps. But then again, you can just use your upper wax rim. Now, one may ask, should we always use a facebow? And what is the argument for a facebow in the world of gnethology, meaning the centric relation world? Aside from establishing an occlusal plane, there's another important feature that they're trying to establish, which has
the arc of closure or something.
Yes.
Right? It's like a big, they love that.
Yeah, the rotation of axis. That's been proven to be highly inaccurate because the ear canal is not superimposing where the TMJ is, and the articulators are somewhat fixed. There used to be a time when there was things like protrusive bites and fully adjustable articulators that allowed you to get there, but it required a high degree of knowledge and clinical competence that the average clinician didn't have, and that's what gave way to the semi-adjustable articulator. And really, most modern comprehensive dentists have thrown the articulator away. John Coyce, who is probably one of the smartest dentists that's ever walked the planet, created something called the Coyce facial analyzer. He does not have a facebow that uses the ears. Yeah, he just uses the aesthetics and the eyeballs, and we'll go over all of that. I just wanted to let you guys know that the facebow is really not that useful anymore. For me, it's useful for establishing the occlusal plane only. But if I have teeth in the arch, or I decide to use the hamular notch incisive papilla access, really the facebow becomes obsolete. And if you talk to many labs, the amount of cases they get with facebows have been diminishing for the past 20 years. In great part because it doesn't do what we thought it once did. I had a prosthodontist in my school who called it the fake bow. And I never understood what she meant because everybody else said it was indispensable. So I just ignored her, and now I realize that she was probably more right than wrong. All right, so we have ways of communicating with the lab. The occlusal plane, in this case, they're really just going to be connecting the dots. Since these teeth are already established, the goal will be to create a valplas partial, replacing teeth 8, 9, and 10. You can talk to them where to place the clasp, but I would just have them create one. They're pretty good at finding the heights of contour based upon surveying. All right, patient has the valplas partial for 3 months. Everything has healed. How do we... Well, before we get to staging, Greenbaum or Stalker, I think you guys had said something about, what are we doing with the bottom down here? What's one big reason why it would be important to give him a partial on the lower?
Posterior support.
Posterior support. That's this guy's problem. He's destroying everything because of that. And Christian, I think we talked a lot about posterior support last time. Yeah, Christian's gone to bed. Elena, yeah, exactly. I mean, this is a biomechanical problem that we have to solve. In order to solve it, we have to create more surface area to distribute the forces. Let's talk about, I wanted to talk more about the upper partial, but in the sake of time, I want to talk about opening this guy's vertical. One of the interesting things about opening this guy's vertical is the fact that once these 3 teeth are gone, the only teeth that are going to touch are these teeth right here. So the sequencing for this guy, and I'm skipping over a lot of steps, but let me just tell you what we decided to do. Christian's going to have the patient come back. We're going to do an open bite with the phonetic bite. So we're establishing an open vertical position that will take into account the patient's airway. They're going to make a wax up of the lower teeth to help restore these. He's going to restore these with composite. We might do a crown on the canines, or at least the distal teeth. But the point is, a wax up will be made. The valplas partial will be made to that wax up at that vertical, and they will wax up number 11. So when the patient comes back, Christian's going to remove number 8, use the Siltec putty matrix to transfer the wax up to the lower teeth so that he can make these into composite. He had proposed the idea that he could do it freehand because he's that talented. I said, yes, you could definitely make these teeth look good, but getting those teeth to look good and be at the right vertical is impossible. So don't get in the trap of trying to do things freehand when you're doing this kind of dentistry. Get your vertical, have the lab make a wax up, and then everything is easy from that point forward. I spent many years trying to do dentistry without wax ups because I was trying to save patients money. Instead, I created headaches for both of us. Wax ups are worth every single penny. So a patient comes in, these come out, valplas goes in, this tooth gets prepped and temporized using the wax up tooth, and the patient will leave with the lower incisors that are all in composite. 2 to 3 weeks later, the patient will then get, at that point the patient's stable with the temporary partial. Everybody on board up to that point?
And you don't have a lower partial at this point, just the upper?
Just the
Right.
upper, yep.
Okay.
Could we do a lower valplast? Yeah. Christian, did we talk about that? I don't remember if we had.
I think we just focused. I mean, he's already going without teeth on the lower right now. I mean, we could, but I also think he's doing all his chewing and functioning on the anterior teeth. If we have a quick turnaround time, I mean, I don't really see the need why we would also need to do a lower, yes, posterior support, but he's also been functional like this for quite some time.
Yeah, the turnaround time to his metal frame partials is very quick. We could do it.
Yeah.
We could. I mean, honestly, I think it's probably better to do it. This tooth right here, obviously, you'd have to decide whether you do that in the first phase or after. I think we had decided that you would pull that at that first.
At the same time as 8.
Yep.
Yep. So that bone and everything heals.
Yep.
So we can do the metal framework trying for the lower, like pretty fast too.
Yep. And then what about the restorations? Did we decide to do that? Yeah, I think we decided to do this after the valplas was delivered, because you're going to have 3 months essentially, or however long you want to let the ridge heal. I like 3 months in a middle-aged man. I think you were going to go ahead and restore these, and we were going to crown a few of them. Definitely crowning 11.
I think we talked about crowning 11, and based off 14, we really can't crown anything else on the upper. We're just going to be updating the fillings, making sure everything's nice and sealed. And then we're going to crown 22 and 27 to help with the lower partial.
I like crowning number 5. Or actually, that would be, yeah, that's 5. Because you can do a surveyed crown. What does a surveyed crown do for us? Where did the name survey come from? I mean, I think everybody gets it, but I think it's good to know, what does a surveyed crown do for us?
We can build in a nice rest seat that's, I think, that's going to help clip the, what I explained to patients. It helps clip the denture, and it's not going to lock in, but it's a really good seat, and it's also not going to wear out as fast as a composite rest seat would.
Yep. So there's 3 things. That would be 1. What about a high to contour?
Yeah, ideal undercuts.
Ideal undercuts. You know, one of the most powerful things we can do for patients that are getting partials is have an appointment where we add composite to select teeth to build the heights of contour or build cingulum rests. It's not often done. I did it for years because I didn't have a thorough planning process. I was treating the patient in the chair. There were too many things for me to try to balance all at once. The patient gets scheduled, they come in for an impression, and I only have 45 minutes. I'm not building heights of contour with composite. You know, I need more time for that. So having a thorough planning process allows us to account for that. But a surveyed crown also allows us to take advantage of the fact that we need retention somewhere. And the path of draw needs to be accounted for, which brings up the final component that a surveyed crown gives us.
Guide plane.
Guide plane. Elena, you're shining tonight. I like it. Where did you went to Tufts?
Mm-hmm.
Yep. Labani and Elena with that strong cross program. All right. So that would be it for the upper. What about the lower as far as crowns go?
So we were talking about doing number 21 and 27 because 28 is going to be coming out.
Yep.
And then we could do additional rest seats, single rest seats, or another type of clasp or anything. I mean, I don't think we got into that detail, but even just having surveyed crowns on 21 and 27 would be huge here.
Yep.
For a nice, stable cast metal partial.
Great. So we're coming up to the end here. I think, Christian, we came up with about 14,000 for extractions, interim partial or partials, a crown on 11, fillings on the other upper teeth, 2 crowns on the lower, composites on the other lower incisors, and the wax up.
Yeah. Gonna be around there.
Yep.
I think it's a badass plan.
When you said bad at first, I was like, oh, man. did we miss something?
This guy, if he comes in and he's like, I only got 14,000, what are we going to do? I'm going to be like, you're getting it all on 4. Absolutely.
And Regan, you're going to follow it up with, I'm going to do it on a Sunday by myself because we're giving it away for 14. That's what's going to happen.
Yes.
Yes.
100%.
Awesome.
Yeah, I think it's a pretty good plan. It helps open up his video. You know, even though cast metal partials, you know, implants and maybe bridge work, it's better. But I mean, for him and the limitations that he's given us, I mean, I think this is a pretty baller plan.
Yeah.
And like, yeah, we're saving money doing some composite work on the front, but I mean, just given the limitations, I think we're taking a whole look at the big picture, and this is actually going to probably last him and be a pretty good upgrade for him.
Yeah. I just wanted to end with another kind of material. I've done 2 cases, and so far they've worked well. This is Glidewell makes it. It's called an acetyl partial. There might be another name for it. It's a 3D printed 3D resin, and the clasps are tooth colored. I have found this to be as strong as metal, but it's somewhat flexible. You can adjust it, and it's much more aesthetic for the patients. With that said, it's new. We should always be careful about selecting things like this for certain patients, but I think it is helpful. And then there's a whole arena of what's called combination cases, where we use an implant or 2 or 3 to replace clasps, and that's something we can talk about at a later juncture. But do keep in mind that world exists. It's a much more laborious process, but it's something that can give a patient a transition plan. Placing one implant for a partial could be one implant for a future all-on-4.